going to discuss our first article, which is a highlight paper in Journal of Orthopedic Trauma in 2014 regarding operative treatment of displaced intraarticular calcaneal fractures, long-term 10 to 20-year results in 108 fractures using a prognostic CT classification. Please feel free to enter your questions and we'll try and answer as many as we can. I'm going to go ahead and start. Thank you for joining us today, Dr. Sanders, to talk to us about your highlight paper, operative treatment of displaced intraarticular calcaneal fractures, long-term 10 to 20-year results in 108 fractures using a prognostic CT classification. So if I may begin, what prompted you to do this study?
Since 1986, really, when I started my fellowship way back in Vanderbilt with Dr. Swinkowski, I've always been interested in calcaneal fractures. When I came to Tampa, Dr. Helfet had recruited me, and Dr. Mass had just left, and Dr. Helfet was doing pelvis and acetabulum, and I was focusing more on lower extremity. And so back then, all the level 1 trauma centers were getting referrals from everywhere. And so I was doing about 70 calcaneal fractures a year. So given that, I started to evaluate them. And we came up with this classification system a long time ago. And we popularized a lot of different things. And now, with a mature practice, I wanted to follow up and see how those patients actually did. I wanted to see whether the classification was still valid. I wanted to see if the classification was able to be prognostic and tell both surgeons and the patients what they could expect with their injury. And that's why we did it.
Can you walk us through your algorithm of what you do for Sanders 1, 2, 3, and 4?
Sure. So the algorithm was pretty straightforward. We realized that a type 1 is a non-displaced fracture in this classification. And so that really just needs non-operative treatment, early mobilization, and once it's healed at about, depending on how much displacement there was, at probably 8 to 10 weeks, they can probably start walking without a problem in a boot and then progress. Type 2 is a simple fracture that should give you an excellent result, and that's an operative case. Type 3 is a little more complicated, and these fractures, if you have a skill set operatively, you can generally return them to almost pre-injury function. So type 2 and type 3 you can operate on surgically with a good result, and we can talk about what sort of an operation you can do. And then the type 4 is a really type 4 and maybe more, right? So those are highly comminuted fractures that really get destroyed. And in those, we really followed Dr. Pennell, George Pennell from Toronto, his ideas from the 70s, which is to fix it anatomically and then go ahead and fuse the subtalar joint. So they really at 3 months, they're completely healed and they can go back to at least some function without being disabled and debilitated for months and months and months. And that's our algorithm.
Follow up to that, questions along the same line with the subtypes for Sanders 3. When are you considering fusing it all for Sanders 3, or are you always fixing them?
So I think that with a type 3 fracture, the real question is whether you can do it through a sinus tarci. And honestly, I'm not that good in doing that. I'm obviously more facile with the extensile, but a lot of these patients come into my office anyway late. So I think that if you are comfortable with the extensile comfortable with the sinus tarsi, and you can get these people right away, you can try to get them and do an operative repair through the sinus tarsi immediately. But I will tell you that we got CAT scans, and it's either just been published or it's being published, where we looked at our type 2s and our type 3s with a sinus tarsi. And the problem is that if you get a plain X-ray, it can cheat a little bit for you on the Broden's views, and you can't quite see the joint reduction if you're not doing it completely through an extensile approach. So some of these look all right on a plain film, and when you get the CAT scan, you can see that a type 3 with a sinus tarsi approach is not perfect. But I know, and I know that Steve Benershka would agree with me, that if you do an extensile approach, you can get these anatomic if you have the skill set and are interested in learning that type of a surgical procedure. So I never fuse a type 3 unless there's no cartilage left. So sometimes you can put these pieces back together. It looks great on CAT scan. You're ready to do it. You open them up, and all the cartilage has been completely sheared off the subchondral bone. There's no point to that because these people are going to get rapid arthritis. And so in those cases, I'll go ahead. Again, it's very important to understand that you have to fix them anatomically so that you have the shape, the length, the height, the alignment. And at that point, you can then go ahead and denude the rest of the cartilage and then fuse them. You can't just go ahead and fuse them because they'll be misshapen. And that's not appropriate for a primary fusion.
Great. You know, you told us about your algorithm, but can you also tell us as to how you counsel these patients based on their classification, their Sanders classification?
Well, it's pretty much the same thing. So a type 1 that's non-displaced, if they adhere to your treatment method, which is not always the case, they should expect a perfect result. With a type 2 and type 3, and more with a type 2, obviously, if you're able to get an anatomic reduction and you can verify that on CAT scan, I tell them they should have really an excellent result initially. And for quite some time, though I never know how much impact they had at the time of the injury. And so they can get cartilage wear down the line. So I tell them at that point, maybe 5, 10, 15, 20 years, which is what I looked at in this study, they may develop subtalar arthritis. And if that's very significant for them, then they would get a simple in situ fusion. And they would notice, and this is, you know, progression from 2 to 3, they would notice stiffness in the subtalar joint, difficulty with uneven ground, cutting, running. They'd start to have problems there in the subtalar joint. And with the type 3s, I tell them it'll probably happen sooner than later, but at least they're shaped and they have more function than if I were to go ahead and do a primary fusion. And the type 4s, I tell them they get a primary fusion, they should be able to go do pretty much everything, but they probably can't run and jump, and they probably going to permanently have problem with uneven ground. It's important, I would say, that when you finally do the fusion, that you don't overcorrect them into varus, because people hate varus, and a little bit of valgus seems to be neutral for most people. So if you're going to cheat a little bit of valgus. Don't try to overcorrect them because they'll fall off their foot when they try to walk sideways. You know, move sideways, they'll fall because they don't have that eversion, and you have to build that into the fusion.
Great. You know, although you excluded from this study, can you tell us your preferred treatment modality for open calc fractures and extraarticular tongue-tie fractures? I know I'm kind
of... So there have been many papers on that, and we had a paper on that as well. I don't think I do anything differently. Basically, if you have an open medial wound, it's not so bad. It's usually where the sustentaculum or body fragment, you know, pokes through. Obviously, if it's a degloving injury, that's a whole different story. That's like a, you know, transcalcaneal tailnavicular dislocation. That's a whole different story. But if you have a poke hole on the medial side, you should be fine. It's the same thing with blisters. If you have blisters, if they're white blisters, it's not a problem. If they're red blisters, again, you have to be more careful. Again, if they're on the medial side, it's probably safer. If it's on the lateral side and it's open, if it's a gash, like a laceration, it's probably okay. If it's a degloving injury, all bets are off because that's a soft tissue explosion and the bone is the least of your problem. And I think that, again, Dr. Panershka wrote a paper, the folks in Seattle wrote a paper where they and this is what we do as well, you can shape that calcaneus with K-wires. K-wire gel, get the talonavicular joint, pin it to the talus as well, and reshape it, and then just wait, let it heal, let it scar down in an anatomic position, pull the pins, let them walk on it, it'll harden, and then when they have arthritis, they can get a subtalar or talonavicular and subtalar fusion electively, and then you have something to work with. So most of the open injuries are type 1 or type 2, occasionally a type 3A somewhere not around your incision, and you can go ahead and do that, but I wouldn't do it for a 3B, degloving type injury.
And then for the extraarticular tongue tie fractures, did you?
Yeah, so they're actually really hard fractures. So there are extraarticular tongues and intraarticular tongues, right? And the intraarticular tongue, we struggle with a lot. Sometimes you have to do a strayer procedure on them, but you can't always get it up. Like you can get it up, but it'll translate on you because of the Achilles. And when you're doing an intraarticular like that, if it's not fresh and you're having difficulty, then what I typically do is I'll do an osteotomy and I turn a tongue into a joint depression, and then I line it back up. And with the osteotomy being oblique, it'll kick back into place, and then the plate goes on. So that's pretty straightforward. When it's extraarticular, that can be really problematic because we wrote a paper I think a year or two ago, where they don't do so well. They pull apart. You put two cannulated cancellous screws down into the plantar surface, it'll rip right off. But you definitely have to do a strayer. You probably have to put these people in a little bit of Aquinas and then walk them up over time. But the fixation falls apart if you use, what do you call them, tight ropes. I've used 2 tight ropes. They've fallen apart. The thing that works the best for me is this technique from Hardy Weber's book from 1983 on special techniques, where he actually uses a tension band. He runs a tension band from a lateral side, he runs it around the tuber, and then he makes a small incision medially, and he passes it back under, and then he ties both sides down, and it's a tension band. And the picture he has is a crocodile's mouth, and you can't open it. And that's really the technique, honestly, that's worked best for me because they can't move it. And for an extraarticular, that's pretty much what I'll do, even though that's, I don't know, 50 years old now, close to 50 years old, it still works.
Great,
There's
thank you.
Nothing new in orthopedics.
You noted about 100% of patients with Sanders 2 and 3 demonstrated radiographic evidence of post-traumatic arthritis, but yet only one-third underwent fusion, predominantly the Sanders 3. Have you noticed in your practice any patient-specific variables that lead to better clinical outcomes, such as
it's
education?
Interesting. So over the years, my partners have kind of pushed me away from acute care, and I end up doing a lot of reconstructive work. So I see a lot of patients that have arthritis in the foot and ankle, and we don't treat x-rays. You shouldn't treat x-rays. You can, obviously, if a patient has a problem clinically and it matches the x-ray, or the x-ray matches a clinical problem, then you have a cause and effect. But there are a lot of people that you look at their x-ray and it's just horrific. And you say to them, well, you know, how's your ankle? And they say, fine, I came into you because I got a hammer toe. Or I came in because I got a midfoot pain, you know, and a posterior tibial tendonitis, a true unrelated. So when I look at these x-rays in this study, after 10 to 20 years, all these people had a varying degree of subtalar arthritis. And remember, we got CAT scans on everybody. So they may not have had the arthritis on the x-ray, but when you look at the CAT scan, you can see changes, right? But clinically, the simpler fractures didn't really have any of the problems. And I suspect, I mean, that's pretty obvious, right? They have more cartilage, less cartilage was damaged. They only had a 2-part fracture. It takes a lot of energy to create a 3-part fracture. And so that extra energy probably obviously destroyed the cartilage of the subtalar joint. And so these people probably have more rapid arthritis. It's clinically prevalent than not. And so that's why I'm being honest, right? Everybody's got, at 20 years, all these people can have arthritis, but it's a varying degree of arthritis. And the people that seem to have the clinical correlation are the ones with a higher grade injury. And that really just, again, this classification has now stood the test of time. I have to say, when we did the original classification, we were just trying to help each other figure out how to operate on these and what worked and what didn't. For me to be able to go back at 20 years and see the outcomes and see that this classification still has merit and still is prognostic was really a little mind-blowing for me. I was very humbled by that because it's you know, just pretty amazing that it works so well for all of this. It really does. It's quite amazing to me.
Yeah. You briefly mentioned on this, but let me just ask one more time. I really enjoyed your debate with Dr. Tornetta a couple of years ago at the OTA. But what role does the sinus tarci approach have in your practice? Do you use that at all, or?
Sure. So they gave me the Extensile, but I try to stay current, obviously, and we try, if it's the right patient and the right fracture, we'll do acute pilons, we'll do acute, talus, obviously, we'll do acute calcaneal fractures if they're simple. And the paper that we published recently, or it's coming out in JOT, is that with a 2-part fracture, if you can get to it, I don't know, within 3 to 5 days, with a sinus tarsi, you can pop it, you can see it, you can manipulate it, and you can get a very nice result very early and allow early motion on these people. The problem with doing an Extensile is that you have to wait till the swelling is down. And even then, you still have some soft tissue problems in the corner with apical wound necrosis. And obviously, people don't like that. The other problem is, by the time you do it and you're at 2 or 3 weeks, the fracture can be very stiff, can be starting to heal, and you can't always get the length out of it. And so these people, because you're doing an Extensile, the subtalar joint tends to be a little stiffer than if you do a fresh fracture through the sinus tarsi. Now, saying that, there are 2 caveats. The first is that it requires a learning curve to learn the sinus tarsi, and the sinus tarsi will work for simple 3 parts, but not for every one of them. And if you wait too long, you'll never get a good result. And if you don't get a CAT scan, you're just lying to yourself. That's number 1. And number 2, if all you know how to do is a sinus tarsi or one-trick pony, and you're going to fall into problems, because if you get these things late, you have to know how to do an Extensile approach. And if you don't, and you do a sinus tarsi, you're not doing the patient a service. So what I would say is that if you're gonna, as an orthopedic surgeon who is interested in trauma or foot and ankle, if you're gonna do a sinus tarsi, you better know how to do an Extensile, right? It's just like if you're a sports guy, and you're doing a shoulder, you better know how to do an open shoulder as well as an arthroscopic shoulder. You need to know everything and have everything in your armamentarium so you pick the right operation for the right fracture pattern. And I would tell you that for a type 2, easy, early sinus tarsi is fine. But for a comminuted fracture or late, or you want to do a primary fusion, you really need to know how to do the Extensile lateral and keep yourself out of trouble. So with both of those, that will really help you be a consummate calcaneal fracture surgeon.
Great. Thank you for sharing that wisdom. Final question. So kind of to wrap this up, what questions do you think still remain unanswered in the topic of operative treatment of calcaneous fractures?
Well, I think that if we could get a better a way to get the sinus tarci approach to give you a more visualization, so maybe a longer, maybe an old Coker, you know, the way we used to do this originally, so just for 1 minute, right? We used to do this with a Coker approach along the perineals, and you could see the whole joint, but you had to move the perineals up and down, and sometimes you dislocated them and didn't quite understand what we were doing. And Diego Fernandez used to do a limited Coker approach, but he would put the patient prone so he could go medial. And so he was able to reconstruct the body with a medial plate and a medial reduction, and the joint through the lateral approach. And so I think we're gonna, once everybody's comfortable with a sinus tarsi, again, it's another learning curve, then people are gonna say, well, I can get the joint, I can't get the body, how do I get the body? I can go distal, I can go get the interprocess, but I can't quite get the body where I want it to. And so people might then start doing, you know, just like you do for tibial plateau, just like you do with a pelvis, right? We're constantly pushing the envelope and coming up with a perfect solution to all the aspects of the fracture. And I think that's what you're going to see, you know, dual approaches for calcaneus. And you probably will be able, because I know I've done it several times, you're able to get it perfect. I mean, really, it's quite amazing. So I think that's ultimately where we're going to go. And if you can do that, then you don't really have to worry about the soft tissue envelope, which is the real key to this whole operation.
Great. Thank you for taking time and sharing your wisdom with us, Dr. Sanders.
Happy to do it. I thank you very much. I enjoyed myself.